Good afternoon, everyone. My name is Damon Lester, and I'm president of the National Association of Minority Automobile Dealers, and welcome to our virtual annual membership meeting speaker series. This afternoon, we have a very special guest. He's a public health physician, professor, and health policy analyst with NBC News. Ladies and gentlemen, please welcome Dr. Vin Gupta. Thank you, Dr. Gupta. Really appreciate it. You taking the time to joining us. I know you're busy doing a lot of these types of interviews, but we thought it was very important for us to have this discussion, particularly as it relates to our industry, which is auto industry, particularly with auto dealerships. And if you don't mind, I'll just jump right on at it and let's get at it. So in previous interviews, Dr. Gupta, you've been sounding the alarm as it relates to the coronavirus and that we're in this state of emergency. Can you tell us why and tell us what you're seeing?
Yeah, absolutely. And first of all, Damon, thank you for the trust and for having me and to speaking to your larger ecosystem. I hope everybody on the call is staying well and healthy, as are your families. To your question, where are we with this pandemic? I think it's a tough question to drill down. I would start by saying, and I say this when I'm on other platforms, your fellow automobile dealers should go to covidactnow.org as a source of truth when it comes to where are we in this pandemic. It's a website that aggregates a lot of data on positive testing rates across the country at the state level. Actually, it drills down to the county level. It looks at what hospital capabilities are like in various geographies and the degree of contact tracing. So how many people, if there's a known positive case in the community, how many of their recent contacts are actually identified and traced so that we can control a potential new outbreak from happening. These terms, testing and tracing and ICU bed availability, we've been throwing them around like they're common knowledge and everybody's familiar with these terms for the last 6 months. This website does a really good job. What you'll see is in my personal opinion, is not good news. And I hate to say that because we've been at this for 6 months. It feels like 6 years, and we're all really tired of hearing the same set of guidelines, the same poor prognostications on the future. What you're going to see is this outbreak. The summer was supposed to be our big reprieve before a potential fall wave, and the summer has proved to be more of the same. You've seen big outbreaks in Texas and Florida. You've seen deaths, the actual total number of deaths spike in the last week to some of the highest levels we've seen since April. And yet you've seen testing decrease. So since July 24th, when testing was at a peak at around 930,000 tests a day, it's about 640,000 tests now. So that combination of deaths either plateauing or peaking with tests decreasing, that's not good. We're having about 50,000 new cases a day in addition to tests decreasing. So it just gives you a sense that this is not because we're testing more. This is because we have pockets throughout the country that have COVID that are uncontrolled, where it continues to spread within the community. And especially now with schools opening up, with automobile dealerships opening up, with the economy revving up because for a variety of reasons, this is going to get worse before it gets better. Is there hope on the horizon? I do think that there's potential new testing innovations like spitting into a tube and getting it tested within 24 hours that are promising. But I don't think there's a vaccine on the horizon that's going to be effective enough to magically make this all go away. So we are in a tenuous spot as we enter colder weather with the flu season on the horizon, which we always know can pose problems. And so we all need to remain vigilant. Pandemics like this take a few years, unfortunately, to truly become less of a problem. And yet we're conditioned to want to restart normal life almost every day we wake up. We're tired of the same headlines. And so it's important to set expectations. It's important to be clear. We're still not through this. We're still not through the worst of it. And pandemics like this that are really bad and have the potential for being even worse take time. They take time.
So Dr. Gupta, let's stay with the testing. So recent data shown that, as you just pointed out, that there has been such a decline in testing. Now, in some states vary on who can get a test and who cannot. For example, so here in Washington, D.C. area, Maryland, D.C., Virginia area, we were initially told you can only get tested if you have symptoms for X number of days, if you had the fever. Is there one set of rules now that anyone can get tested, even just to make sure that you're not testing positive, or if you're asymptomatic? What is out there? What's the information out there now? Because it just seems that it's just all over the place, from state to state.
Well, Damon, you're right that there is not a set of clear guidelines that I am aware of. And there's been a ton of confusion, speaking candidly, on what the CDC says one day and what then they say the next day. And so if I'm listening to this, I'm confused. I mean, as a clinician caring for these patients, I'm confused. I can only imagine people that hear these headlines are wondering what is going on. And so my experience has not been that if you want a test, you can easily get a test. It's been, if you want a test, maybe you can get a test and you can get a result back within 5 to 7 days, potentially. And that's part of the reason why you're noticing, Damon, test numbers declining over the last 2 weeks. People, as I understand it, I've seen personally, are just fed up. They don't want a test that takes a week potentially to get a result, because that's useless, right? Because you could get re-exposed, and then if you want to go, let's say you want to go visit grandma, grandpa, or your folks, somebody that's would potentially be really vulnerable if they got exposed to COVID-19. If the last test you had was a week ago and then you had to hop on a plane, is that useful information? Probably not, because you could have gotten re-exposed and you might be a threat to people, even if you're okay, to others. The truth here is, and I have a prop because I'm a visual learner and I like to see things. I won't show the name of the company, so this won't be a commercial, but I've had a chance to have a few of these types of devices to look at, to clinically vet. This is a device from a company in California. It's a rapid point of care test. And what is the idea here? The idea here is you swab yourself in your nose. It's a nasal swab, and you basically, through a few very easy steps, you put a cartridge in this little mini lab. This is a lab, basically. And this approximates the quality of tests that could be done in a lab in a hospital. We need more of these guys, Damon, for your fellow colleagues, for school teachers, for individuals that want a test that's useful to get a test. We just don't have enough of these guys. Now the government is kicking in. They put almost $300 million towards development of these tests, towards the scaling of them. But let's be frank, $300 million is a drop in the bucket. These things are expensive. So we're talking about our kids going to public schools needing, and teachers in those schools needing these tests readily accessible so people can get these tests with the throughput that they need. That's going to take money on the order of, with some estimates, $75 billion for us to get the tests that we really need here, not the swabs that take a week. So right now our testing programs have failed. They've failed broadly for the last 6 months. People are frustrated. And part of it's we just haven't had our eye on the prize until now. And now it's going to still take 3 to 4 months. This is not going to go away. Right. It's going to take some time before everybody can get the test that they deserve.
So to your point with the test, and this is an airborne disease, right? And Duke University recently came out with a study that said, certain masks are good masks. And I got some props too. So I have this mask, which is the neck one. Then I got the double vented mask from like when I'm riding or working out. And then I got this doctor's thingy, this one. And then I got one more, this one. So I got masks galore. So is there a difference in an outdoor mask that you should wear versus an indoor mask at home? Or even is there a mask that you should wear that's best to be used in the workplace? Because these aren't that easy to breathe in if it's like 90-degree weather and humid. So what's your advice on how we need to maneuver with masks?
Yeah, no, it's a really important question. My first advice would be So there's a lot of complications here. Let me step back and say, what is an airborne disease? What's a droplet disease? All these confusing terms. You know, when I'm in the hospital, they have to put signs up to remind folks like me what that even means. So then yet we're using this like in everyday parlance as though people just get it. So an N95 mask, folks probably on the line have heard this term now before, a green mask, N95 mask. This is a mask that needs to be properly fitted to the individual. And if it's done so, can filter out 95% of the of particles in the surrounding environment, in the air that you breathe. Meaning it's going to protect you, we hope, against airborne respiratory viruses. What does that mean? Tuberculosis, measles, these are viruses that are airborne historically, where if I've ever encountered a patient with one of these deadly diseases, I have to wear an N95 mask in the hospital setting. What's tough about COVID is that we think it's airborne now. What's airborne? Airborne basically means if I cough or sneeze, if I just talk, I'm actually, if you put your phone up against your mouth and you just start, and for the duration of when you're just speaking, you'll see you're spraying the phone with a bunch of saliva droplets. Droplet transmitted disease is basically the big saliva goombers that you're releasing every single time you talk. Airborne is basically just small droplets. So it's all droplets. It's all these saliva balls that you emit when you speak or when you talk, when you sing, when you yell. If they're really small, they're called, if a virus is transmitted through airborne routes, it just means that COVID-19 is sustaining itself and is alive in the air in really small droplets.
Right.
Influenza is large droplets, these like big goombers that then will fall down to the ground around the person that's emitting it within, say, a 6-foot radius. Those airborne droplets are worrisome because they can travel, they're small, they can travel further, and they can sustain themselves in the air for a lot longer. That's why in the hospital, when we encounter somebody with COVID-19, we wear one of these guys because this is critical to protecting against these small droplets that might have COVID. Okay, so what do we do with masks? The surgical mask is basically no different than a thick cloth mask that's well fitted, made from cotton. So a thick cotton mask, maybe even with a filter within sort of 2 sleeves of the cotton, is no different in effectiveness than a surgical mask. Mm. Let's be clear, any of the masks that you just showed, aside from the bandana mask, which is not effective, I would never recommend anybody to wear one of those neck gaiters, right, where it's a thin polyester material. Those bandana masks are not good. There's now enough studies to suggest bandana masks are definite no. These masks or cloth-like masks that look like a surgical mask that somebody's wearing in the hospital, right, these are good against droplets, those big goombers that people will be releasing. So you're protecting yourself or you're protecting others if you're shopping in a grocery store, if you're an automobile dealership. I'm not gonna lie to you. In a perfect world, you're wearing an N95 mask. Right. So if you're and that's the big thing. No one wants to say, I don't want to frankly say it because we don't have enough of these guys. So it's going to create a lot, mayhem if I say it. But the reality here is we need high quality masks for everybody. You can get yourself a KN95 mask. Go to Amazon, go wherever, type in KN95. It's almost as good as an N95, but it's not graded as such. So as a doc in the ICU, I can't use it to protect myself, but it's better than these guys, we think. And if I'm an automobile dealer, if I'm in an indoor setting, interacting with people all the time, I probably would want a KN95 mask before a surgical mask because you're gonna protect yourself better.
What about these masks with the double vents? And then you have the mask with the single vent with the insert of this thingy here. How are these good? Like, they're now promoting them. These are good to wear when you're working out because they have the vents. And are they?
Here's what we know. What we don't know is how good they are in protecting you against these small droplets. We know that those types of masks are largely good against these big droplets. So I think in most cases, um, those are fine. But all of you on this call, to some degree, are being exposed in indoor settings to people you don't know their COVID positivity status. If it was me, and if I was determining policy, I would say go get yourself a KN95 mask. It's almost as good as this. We just don't truly know, but it's a step up from the mask, and it's been more tested than the vented masks, Damon, that you just showed. Do I think there's a clear difference? The answer is I don't know, because the study hasn't been done comparing the mask you just showed me with the double vents to a single vented mask to a surgical mask or KN95. No one knows the answer to that. Do I think that there's probably some marginal benefit to a KN95 mask? Yeah, I do.
Well, I'm going to kind of pivot to another topic. So studies have also shown that ethnic minorities are disproportionately affected by the virus in comparison to others. Has there been any true research done to validate that? If so, why? And why do you think, in your opinion, why do you think that we as minorities are more prone to catching it?
So it's a really important question. What I would say is what we know is that right now, the studies that have been done in the last 6 months don't definitively conclude that there is a genetic predisposition or a genetic risk to a worse outcome if you're black or brown or any member of a minority group, that somehow you have a genetic risk that is associated to a worse outcome with COVID-19. We just don't know that definitively. What we do know is that there's an unmistakable link between poor pre-existing somebody with a poor health beforehand and a worse outcome. And what we also know is that generally speaking, minority groups have worse health or at increased odds of having worse health than non-minority groups. It's just a fact that sociodemographic characteristics, socioeconomic characteristics correlate well with, we Black and brown communities, other minority groups tend to be poor with per capita income, tend to live in inner urban cities where they're more exposed to air pollution. So they have risk to have less access to durable healthcare. These are risk factors then for poor health. Right. What happens if you then have poor health or you have diabetes or poor lungs is then you're more exposed to COVID-19. So there is definitely a racial component to who bears the burden of COVID-19. Is it because of genetics? We don't know that. But is it because of larger structural problems in terms of access to healthcare and other issues that I won't go into when it comes to social justice in our society? Absolutely. But I'll leave it at that.
So everyone that's on today, please feel free to send your questions in to chat, and Dr. Gupta is going to answer as many of the questions as we possibly can get to. So Dr. Gupta, within our dealership body or within our membership, we've seen an increase in some positive cases amongst our dealership employees and dealers having to sanitize their stores and quarantine workers. What protocols need to be put in place for employees who have tested positive? And do they need to contact the customers who've come into the dealership from either direct contact or indirect contact? And also, how are employees supposed to communicate this to their employees? How do they handle this?
So I have a lot of sympathy for everybody on the call that we even have to ask this question, because this is not a burden that should be placed on businesses. Businesses should be given guidance on what to do from state departments of health and given the resources to contact trace. Damon, I mean, to put it another way, you're effectively asking who is responsible for contact tracing of a positive individual, say that may have entered a dealership, or an employee of one of these dealerships that was positive and may have exposed customers. In my personal opinion, this is my opinion, that is, systems should be in place from that have been developed, that might be app-based or some combination of app-based and manual-based, so actual physical human beings doing contact tracing, that that all the businesses or that any dealership should be able to leverage in the setting of a positive COVID case. So I don't think these are responsibilities of an individual dealership. I think every dealer needs to cooperate with the Department of Health and other authorities that are tasked to do contact tracing, and any other, state-based variations. Everybody should cooperate with it, right? Because contact tracing is only as good as people are willing to provide information and cooperate with, whether it's a technological platform to contact trace or manual calling people. But do I think that in any way you should be responsible for notifying authorities? If you have information about an employee that has tested positive, typically the Department of Health should also know that. Whoever was the testing authority, a hospital, a clinic, what have you, any positive cases must be identified in most instances. And again, there's some variations at the state level, to the state or the local Department of Health. And then those individuals, presuming, again, and there's a lot of variation across the country, those individuals at the state and local Department of Health should be able to leverage a contact tracing effort that should not put any burden on employers, because I think that's the thing here. We don't want to burden employers to do the job of public health institutions, because everybody on this call has their own individual expertise, but I would say that their expertise is not necessarily in public health, nor should we expect that. And so that's really important to emphasize. So I'll pause there. I don't know if you had any follow-ups.
Yeah, so well, I guess if you can touch on this, so many companies out here now that's saying, hey, we can sanitize your office, we can sanitize with these sprays that most people really don't know what the heck is in this spray and just leave it on there. Is there a certain formula that needs to be in there, just like our hand sanitizer should have over 70% of alcohol in it? How is the sanitation process for sanitizing a store or office? Does that differ from the hand sanitizer requirement?
So, industrial uses of sanitizing sprays, there are a lot of applications now. There's a lot of companies selling that, to your point. So does it differ? It definitely differs to some degree. Some of them are less alcohol based. I wouldn't begin to speculate on the actual components, but I can certainly share the information I do have after the call. What I would say is, any employer, this is where there will be an expectation of workplace health and safety protocols being implemented to keep people safe and to mitigate transmission. Any employer, and especially any employee, is going to want to be working in a place where there's frequent cleaning, especially of high touch areas, so doorknobs, workplace benches, shared communal spaces, the kitchen, the break room. We even consider shutting those places down. Frankly, I've seen a lot of workplaces just shut those places down, so there's minimal congregation. There's unique ways to think about how to keep workplaces safe and healthy without having to necessarily over-index on, wow, every 4 hours I got to spray the whole thing down, because that's also just not practical. But I think high touch areas with your usual, antiseptic cleaners, the Lysols, for example, that are great for home-based cleaning, are also effective for workplace cleaning, especially, if you're not talking about huge warehouses. You can think about a tactical approach where a janitor or your janitorial staff, your custodial staff is really focusing in on high touch areas, maybe 4 times a day during a work day. There's some organizations, hospitals specifically, that are high transmission areas where there's actually technology that's placed on the floor, sort of like a mat on the floor, that on contact with the individual's sole, their shoe sole will kill viruses and bacteria. Is that truly tested? Who knows? And so this is where ventilation systems, HVAC systems that have UV lamps on them and other airborne air filters. There's a whole industry that is being spruced up now to make for workplace health and safety. And that's where it's important to say what is evidence-based, what's not, what's been tested, what's not, because all this stuff's expensive.
Right.
I think the biggest, like the highest yield, since we're all trying to be cost effective and mindful, is to the extent that you can be outdoors, especially in automobile dealerships, be outdoors. The extent that everybody can wear a mask, a KN95, do that. The extent to which you can keep windows open if you have an indoor dealership and you gotta be indoors, ventilation is huge. And there's no fancy HVAC system that's out there that's gonna replace just opening the windows or just keeping, you know, depending on the dealership, like walls open. And then I would say high touch areas should be cleaned with, you know, regular home grade antiseptics, like, you know, your Clorox wipes. That will do the trick. Beyond that, I would recommend shutting down kitchen break rooms for the foreseeable future, and people just have to mind their breaks at their own desks if they have them, or in other sort of modified areas. But social distancing for breaks would be important as well. But yeah, I'll pause there.
So as it relates to the, you know, the employees of a store, of a dealership, which is what we're talking about today, you know, you have the work life, the dealership may require a mask, but everyone has to go home. You're not quarantined in your dealership or where your place of work. How can employers mandate or maybe put a protocol in place that best practices also need to take place at home? Yep. So that if everyone is protected, you know, because you go home, you go to a family, you're in your cookouts and people are gathering around and not having masks on because they're family or close friends. But then you go back home, where you go back to work the next day and you have to wear your mask. Or is there anything that you would suggest that employers need to, I guess, instruct their employees on how to keep safe home and vice versa? Is there a protocol? Can that take place?
It's such a good question, and I'm going to just speak candidly, since I don't think anybody has time for beating around the bush here. This is where there's just been failure of effective messaging and leadership. The fact that you have to ask that question basically like makes it clear that there's a lot of confusion about what is it that we should and should not be doing at home, and the fact that we need to reinforce that message, which I agree with you, we do. Truth is, there's nothing you can do to stipulate how somebody outside the workplace behaves. And every organization, whether it's a healthcare system, whether it's large companies doing essential tasks, automobile dealerships, for example, everybody has to assume that everybody else is abiding by the honor system of common sense, you know, so how you message on that, if it was me, I would message very clearly that these are the things that we need people to do for them to continue to come to work and to have a job and to sustain themselves. So I think this is part of, like, how do we make sure that we don't shut down again? And using language of, like, how do we keep us open and trending towards normalcy versus having to trend back towards something nobody wants here, which is sheltering in place. That basic things that, you know, my family and I try to abide by are, you know, if you have to see people that are not part of your immediate living situation, it needs to be outside under any circumstance, and it needs to be socially distanced and with no groups of 5 or less. So those who don't live in your nuclear family, 5 or less in an outdoor situation, ideally social distance. That's the way. The fact that we're even allowing that, some people would say, well, you know, we're in the middle of a pandemic. It's a once in a century pandemic. That doesn't make a ton of sense. And the truth is, it doesn't make a ton of sense. Right. But I think that's where we've decided we're willing to tolerate some degree of dipping our toe in the water and seeing what is and is not gonna promote the next outbreak. So minimizing social engagement, but doing so safely and with proper precautions is vital. Outdoor, small groups. Masking in public. So when you're grocery stores, coffee shops, whatever it might be that you do in your free time to get leisure, please wear a mask. And I think to stipulate that to your employees or to recommend it in ways that are that they will receive it, it's just good reinforcement. People, you can never say this enough times, and people think that there's, I do this all the time, so I'd like to think that people aren't just tired of me saying it, but I'm sure people are exhausted with it. So having protocols in place, maybe even having a weekly email listserv where you remind people on Monday or on Sunday night, these are the things you can do to keep your family safe, to keep yourself safe, and to make sure that we have continued operations and that we don't have to shut. Sort of put out there the threat of what happens, but in really accessible ways. If we don't do the things that we should be doing, nobody's going to want that, especially as we enter the fall wave. And then usual infection control measures. So to me, it's not complicated. None of this is complicated. It's just there have been factors that I'm shocked, and I think we're all sort of surprised that have been interjected into this conversation that have politicized a lot of the stuff and have made it a lot more complicated than it needs to be.
I have a question. So this relates to restaurants. So they're limiting. Many restaurants are limiting, or the states are limiting the number of people that can eat inside the restaurant. You must have your mask on, but when you want to eat, take your mask off. Doesn't that just defeat the purpose of what you just talked about with droplets, big droplets, little droplets, mask off, mask on? That's the question. So eat outside if you can, but how do you handle that? Because I'm not going into a restaurant to eat. I have anxiety.
I think this is part of it, for every dealership on the representative on this call, and just for you, Damon, more broadly as the organizer here, I would say whatever that weekly email looks like to all the members of this association, it should also come with a suggestion. I would view it I would term it in no uncertain terms. I think often in public health, there's too much caginess, too much, well, let me talk nice about this. I think people need directness, and they need expectation setting. And then we tend to do good if we have good expectations of, okay, this is going to be tough for the next 3 to 6 months, but at least I know so I can adapt, versus, well, I don't know. On indoor dining, the verdict here is clear. I just don't do it. And it's still summer. There's still a lot of places that are doing outdoor dining. So if you need to I get it. I love to dine outside too. Just do it outdoors. I've done it. And I think done smartly. And most restaurants I've seen that are doing outdoor dining have great social distancing. It's outdoors. And it's pleasant outside. Eat out. No one's saying don't eat out. Just don't eat indoors. So avoid restaurants that don't have outdoor dining. Very simple. And I agree with you. The ones where it's like, well, have a mask on, but then if you want to have a beverage and eat, feel free to take it off. What else are you doing in a restaurant? So I would avoid it.
Okay. And this is that's the last question. I guess are there any takeaways? Can you mention the website again? And also if you touched on vaccinations, and as we approach the fall months, particularly here on the East Coast, and things are spiking. We see UNC has had to shut down because it's the college kids have tested positive. What are some additional takeaways, the social distancing, mask, and anything else that you can share as it relates to make sure people are healthy and protecting their family, kids from schools and things like that, especially kids who are going back to school? Is there a way to sanitize them when these kids, particularly the little ones, can come back home? Do you spray everything down, or how should you operate with that?
You know what? This is what I do when I come back from an ICU shift. My wife's a pediatrician. This is what she does. We put all our shoes outside or in a garage type setting. We immediately try to take a shower. and avoid contact with anybody. So we're in a hot shower, and any belongings that we have, we keep either in the trunk of the car or outside the home where there's a risk to touch it. So I would say for book bags, things that you don't have to bring in the home to clean, so basically anything that's not a lunchbox, I would try to keep that outdoors. If kids are bringing back books, obviously there's, you know, there's some degree of just like what is reasonable to, you gotta, you know, kids have to be able to kind of utilize their books. So the extent to which books have to actually be taken out of the home into the classroom, maybe hopefully teachers and schools are going to be reasonable when it comes to how many things are physically coming from the home into the school and back. I'm hopeful that schools, and this is a vary, are mindful and thoughtful about, well, do we need to have everybody bring in a book, or can it just be a notebook? But minimizing sort of transit of objects and things that don't need to actually physically enter the home is key. Try to shower your children as quickly as possible, and shoes. Keep the shoes out. Those are simple things that, you know, in the healthcare world we do, and I think can easily be transposed to school-aged children. What I would recommend also is that, and this is tough, but you know, children that are going to and from, the biggest concern here is not children getting ill, but children getting their parents or their grandparents ill. And so people that are particularly at high risk of a bad outcome from COVID-19. So if some of you have family members that are really at high risk because they're on, and they have rheumatoid arthritis, and they're on a really powerful drug to suppress their immune system so that they can live their life. They have a GI problem, you name it, diabetes, high blood pressure, things that we know are not good and could cause problems if they get COVID-19. If there's a possibility to have an alternative living arrangement until there's a vaccine, or until things clarify themselves, it's still going to be, you know, into 2021, I would consider that. I would consider that a lot. And I recognize that that's a hard thing to say. Well, you know, let's figure out an alternative living arrangement for people and families on the fly here. But that's the way, unfortunately, we're in a once in a century pandemic, we think, hopefully. And it's going to require outside the box thinking. But if children are going to school, minimize contamination of the house, shower quickly, try to minimize exposure until those interventions have been employed to people that are at particularly high risk of a bad outcome of COVID-19. Consider, if you can, maybe alternative living arrangements if it's within the realm of possibility. If not, then it's going to be much more of a focus on minimizing infection risk. And if the risk is just too high to people at home, then that's when you have to think about a virtual only solution. Or if children have pre-existing conditions, asthma or other chronic conditions for whatever reason, those are the types of conditions here that would warrant, okay, well, I think until this passes, maybe we just have to do tele-learning environments. And every school district should, as I understand it, have an option for those individuals that cannot, or for those children that cannot come back into a brick and mortar learning environment.
Well, Dr. Gupta, we appreciate you joining us today, man. Thank you for taking the time. Much appreciated. Very informative. I hope everyone on here today enjoyed themselves and got a lot of information as he's given us, and cleared up a lot of things for me, particularly with the mask. And so Dr. Gupta, thank you. Hopefully we'll have you back next couple months. Hopefully things will slow down and there's a vaccine that's out there, and we'll ask for some assistance, some guidance from there. But thank you again, and enjoy the rest of your day. Be safe, wear your mask, everyone, and have a great day. Thank you.
Thanks, everybody. Thank you, Damon, for the invitation.